What's up, everybody? Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And I have one of my most favorite people in the whole universe on the call today. I've got Dr. Suzanne Ferree. Did I pronounce it correct?
Absolutely.
Okay, because I was practicing all morning. I was like in the mirror, Ferree. So Dr. Ferree is... she's been like a mentor to me. I feel like she's helped really mold me into the provider I am today. Without her, I would not be the same. So I've got her on here. She's been a guest on our podcast, I think 2 other times. And so I'm gonna get a little bit into her history, but we're gonna dive deep into some of the hormone stuff. So she's very well known for longevity and optimization. She most recently wrote a book called Counterclockwise, correct?
Yes.
And it's great. I've read it. I'm just waiting for the Audible to come out so I can read it again, basically. I'm going to say, Suzanne, can you read to me, please? And so, Suzanne, let's talk about it. So first of all, tell us kind of where you're at and what your practice is mainly, just in case in case they're new to the podcast.
Okay. So I'm in Atlanta and I have 2 sort of categories of patients. One is the unwell patient who has Lyme, mold, MS, autoimmune disease, other things like that. And then I have the other end of the spectrum, which are the super healthy entrepreneur biohackers that really want to just be able to continue doing what they're doing, and they don't want their health to interfere with their ability to continue their high level performance. So that's what we see, both ends of the spectrum. And everything started out when I was, a patient came to me and asked me to write bioidentical hormone prescription. This was probably around 2005, 6, 7, somewhere in that range. And I wrote the prescription to the compounding pharmacy, and the compounding pharmacist said, "Hey, you don't know what you're doing."
Happened to me too. That happened. The same thing. They're like, "You're trying, but I can see you don't know what you're doing." Yeah.
Yeah. And then they sent me to a conference. He said, "I'll pay for you to go to this conference if you'll go." And it was called Get Out of Line. And it really just was like the scales fell from my eyes about the things that were happening, and that there's so much research out there. This is my huge soapbox right now, Lexi, is there's so much research out there and doctors don't have the time. I understand why. I have the time. I'm grateful for it. But the distance between bench medicine, bench research, and clinical practice is so vast. And so I'm hoping that you and I and other providers like us can be the stand in the gap for that place and say, look, you have to look at this. You and I both have gotten sort of irritated, turned up the hornet's nests around us of the providers about things like hormones, things like peptides that are not mainstream medicine, that are not supported by a pharmaceutical company. And so our methods are, although they are a little bit outside the box, they are supported by quite a bit of research. So we're not doing things. I know you, I know how you work. We're not doing things that are unsupported by research. And we're just bringing them to the table and saying, hey, this is something that might have benefit in you. Would you be willing to try it? Because most of our patients, I'm sure yours too, are coming to you having already been to a lot of other providers and been unsuccessful at their treatment with other providers. And so when they come to us, they don't want the standard conventional things. They've already tried those things and they didn't work. So we are standing up saying, we're going to do the research. We're going to find other things that are available that might be helpful for you. We know they're outside the box, but we want to see you feel better, and this might be helpful. And so many times when we make that leap, we see a difference. And then bioidentical hormones are really one of the places where we see that being beneficial.
Absolutely. So one thing, I don't know if you remember, this is like probably 2 years ago, we did a podcast together and it was like hormones and like the menopausal patient. And when I'm talking to a client, I use the same kind of analogy that you taught me many years ago was, testosterone is helpful for women in that it can help with cognitive function, it can help with energy, it can help with motivation. Most importantly, and I know you're the same way because we speak the same language, is muscle mass. It can help so much with maintaining muscle mass, and that can help with longevity, right?
Yes.
The other thing that I feel like often in traditional medicine, they associate testosterone in women with just sex drive and libido. And when I'm going through my consult, that's like at the bottom. That's like, oh, by the way, your libido might get better. And I'm like listing all these things. But one thing you've always said is you're like the estrogen, though, it's like the I feel sexy hormone. And then the testosterone's like, I want to have sex. And so I think it's very important for listeners who are patients to really identify that it's a symphony, right? And they all all have to like play well together. And then progesterone kind of comes in and kind of calms things out, and estrogen kind of lubricates it up. And but they all have to play nice together, right? So I think, Suzanne, let's start off with what types of HRT do you offer? So HRT is hormone replacement therapy. What are the different types that you offer? Because what I love about you is that you're not just one way. You offer lots of different options. So talk through kind of some of the different ways for women that you provide hormones.
Well, we know that if you give, so first of all, we're exclusively bioidentical hormones. And what I mean by that is it mimics the same chemical structure as the hormone that your body naturally produces. So as opposed to birth control pills or hormone replacement therapy like Prempro, that is not bioidentical, meaning it is a different chemical structure. Now, it works great for protecting the uterus from uterine cancer. But other than that, that is not the same chemical as what your body does. So it doesn't do the same things in your body. What I want to do is just mimic the natural hormonal milieu of a slightly younger woman. So if we're talking about a 50 or a 60-year-old woman, I want her to be more like 40 or 50 years old. I'm not trying to get her to be down to 20. I just want to turn the clock back maybe 10 years and see if we can restore some of that optimal function from where you were. And so in our practice, we use lots of things. We'll use usually topicals, like topical cream. The upside of the topical is you can change it anytime. If you don't like how it works, you change it tomorrow and then your body responds. The other options are injectable. Similarly, it gives you about 1 or 2 days of benefit, and then you can change the dose if you like, or if you don't like whatever was there, you can change the dose. So those two are very flexible. The third option that's also somewhat flexible is using a troche. This is a little sort of like a gummy that goes between the cheek and the gum. It gets absorbed directly through the buccal mucosa. Now, unfortunately, a good bit of that gets absorbed orally. And we know that through a lot of the testing that's been done, that oral absorption of hormones does increase liver toxicity as well as turns the body's detoxification pathways on in a way that is not supporting optimal health. So we don't like to use hormones orally if we don't have to. And so that's not my first choice. I do have maybe 1 or 2 in our entire practice patients who just did not tolerate any other form, and that is the form that we settled on for them. But they are very, very closely monitored, their liver function, their hormone metabolites, all of that, to be sure we're not causing them more problems. We also do subcutaneous pellet therapy, and so that's excellent for a lot of our patients who travel a significant amount. This is the reason why I love pellets. So right now I have a client she's just finishing up tomorrow a 6-month cruise around the world. And so what was an optimal thing for her to take on her cruise around the world so she didn't have to worry about refrigerating anything or taking needles with her or applying a cream every day while she's on vacation? We did pellets for her before she left. And we tested a year ago what a 6-month dose would be for her.
Oh, nice.
So a year ago we tested it, knowing that this trip was coming up. And then she's been on her pellets for the last 6 months. She's got an appointment scheduled for next week to come in and get her pellets replaced. But so it's perfect for some of our clients. It's not perfect for everyone. And we usually will start with something that's a little more flexible. The patients can test it out, see how the response is, get that symphony working right and all the instruments tuned up. And then we can switch over either temporarily or permanently to pellets as the patients tolerate.
Right. Yeah, that's perfect. That's perfect. I think one thing, I don't know if you remember a couple of weeks ago, it might have been a month ago, I had emailed you about so this oral estrogen troche, it's not my favorite. Like, what if they swallow it and it goes in the gut? And what about first pass? And you're like, those were my thoughts exactly. And I'm like, okay, good. Just wanted to hear somebody else say it too. So yeah, so Suzanne, can you explain, because I get this question a lot, prometrium. So prometrium is bioidentical progesterone. I would say this is very easy to get, very inexpensive, works very, very well. How is that not causing issues in the first pass? Because I explained it a certain way to patients. I'd be curious to see kind of how you would explain it.
So about half of the prometrium is the brand name, progesterone. And please know there's a big difference between progestins, which is in hormone replacement, most hormone replacement therapy,
birth control.
and birth control pills. So that's what's in those things. That's not what we're talking about using. We're talking about using actual bioidentical progesterone, same chemical structure as what our bodies use. When it's taken by mouth, half of it is converted to what we call allopregnanolone, which is so great. Sorry, not half of it. A good part of it is converted to allopregnanolone. Allopregnanolone acts in the body much like alcohol or Xanax. It is super calming. It binds to those beautiful GABA receptors, which helps to regulate all of that anxiety or tension that our bodies feel as we get closer to menopause. You know, people get irritable and more stressed out and it really helps to mitigate a lot of those emotional symptoms that go along with perimenopause or menopause. And especially because what we typically will see is progesterone is the first one to dive. So when we begin to replace progesterone, sometimes that's all women will need is replacing progesterone at the beginning of their cycle. Now, if you replace too much progesterone, one of the things that my patients will often report is muscle and joint tendon aches. So they are more susceptible to injury in the gym. They're more susceptible to having more difficulty with recovery from injuries or susceptibility to injury. So we just need to balance that out with our patients who are in the gym, making sure that we're not overdosing their progesterone. And that's just stuff that we follow with urine, saliva, and or blood testing to help sort of optimize those levels. And then listening to our patients, I think, is one of the things, especially Lexi, that you're really good at.
Yeah, no, absolutely. Yeah. I kind of talk a little bit about the first pass and we talk about metabolites, and it's like when you're synthetic, and you know, it's so frustrating. And I know you read research more than I do, is they'll talk about progesterone, blah, 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 blah. And it's like, whoa. Are you talking about progestins? Or are you talking about micronized progesterone? Because they'll title it and it's clickbait, right? So it's like, oh, this progesterone is bad. It's like, Go back down into the study. It's talking about progestins. It's completely different. Yes. So I so wish there was like a standard that, like, if you're talking about progesterone, please identify, like, I am progesterone and I'm identifying as progestins in this study. Like, can you please identify who you're talking about here? Because that can be
we need a pronouns.
Yeah. Can I get an adjective or a pronoun or something here? So the reason why this beautiful woman is helping me spread the hormone gospel is because I wanted to talk a little bit about the WHI. So the WHI is the Women's Health Initiative. It was a study that came out in 2002. And what it studied it was a big research study. It involved more than 16,000 women and it was designed to evaluate the risks and the benefits of HRT. There were so many flaws in this study, but the problem is that with this study, despite all its flaws, they over extrapolated results that then scared many physicians and not all that many patients. And so I was working on, Suzanne, I'm always working on Instagram posts, because how you teach and how you learn, and you're like, you love to teach because it makes you a better student. That's how I somewhat feel about social media, right? So I'm always doing content and things like that. And one of the titles that I was creating is like, if I was a boomer, I would be pissed because it's like, these poor women are just like suffering going through menopause because their doctor saw this title of this article and really didn't dig into the research. And then what's even more annoying is in 2006, the rebuttal of that study came out and was like, okay, guys, sorry, we actually didn't interpret the data, correctly. We kind of started a little too late. And the nurses that they put these hormones on, maybe weren't the most healthiest of people. And it's like, well, shit, that didn't make a big media splash. Why not? And so it's kind of like what I'm here to do with you, like many of our comrades in this industry, is like trying to set the record straight in that, unfortunately, there was actually some really good information that came out of that study. So, Suzanne, I'm assuming you were practicing when this kind of study came out, in 2002, just so you know, I was graduating high school. So I was still a little baby in the sky. But, so like, how did it affect your practice?
So it's pretty amazing. I remember when this came out, and I was regular allopathic medicine at the time. So I had put all of my menopausal women, so really there was two choices of how you treated women. Number one, you put them on birth control pills until they turned about 50. And then when they turned 50, you switched them over to hormone replacement therapy. Boom, that was easy. You didn't have to think as a provider. You just, how old are you? This is your drug. This is your hormone therapy that we do for you. And so there was no thinking, there was no researching, there was no following their labs, there was no looking at their history, there was no making sure their liver enzymes were fine, there was no talking to them about gut health. None of that was going on. And so I am one of the guilty, many physicians of the time. So because I didn't even realize that bioidentical hormones existed. I didn't know there was such a thing. I didn't even know there was a compounding pharmacy available. So this is just ignorance. I'd fallen into the trap of this sort of lulled brain of the pharmaceutical companies that had really, we are where you learn all of your information. Don't look at anybody else. Pay no attention to the man behind the curtain. So we put everybody on PremPro effectively, or I think there were some alternatives to PremPro at the time, but they weren't very popular, or they didn't have very many salespeople. And so we put everyone on PremPro. Then all of a sudden the WHI came out, and there was a lot of pressure to take everyone off of hormone replacement therapy. So I went through and took everyone off of hormone replacement therapy. And I am so sad about that, because I wonder how many women ended up with osteoporosis, heart disease, dementia, so many other disease states, depression, hospitalization due to depression, because we took them off of their hormones, which were at least helping them to some degree, because PremPro contains a little bit of estradiol, which is the natural hormone that your body produces. It also contains some other non-estrogen, not estradiol chemicals. And then it contains the progestins, which tend to be the more problematic hormone that's present in the non-bioidentical hormones. So we took everyone off of them. I'm sure there were a lot of people who had terrible side effects and problems as a result. And people started coming back to me. And that was when someone came to me and said, "Hey, will you prescribe me this bioidentical?" And I was like, "I don't know what you're talking about. I don't know what that is." So it's been a journey since then to learn what is out there, what's available, how to follow it, how to test it. That was back in the early 2000s when we began doing this on a consistent basis. And I was, like most of my colleagues, even today are, if I refer patients to an OBGYN, almost always they have no idea what I'm talking about. And if they happen to have heard about it, they haven't done any research to figure out, they don't know what to do. So it is an interesting challenge as a provider. You and we have come up butt heads with a lot of providers who just don't know. And I would happily show them. There's tons of research. There's article after article after article. I'm so grateful for being able to study under Dr. Uzi Rice, who was able to show me we did a real disservice to these women. And the first time I ever heard him lecture, I sat in the lecture hall and bawled my eyes out, because I know that I harmed some people, and I didn't know it at the time, but wow, what a horrible thing to realize. And then now the only thing I can do is move forward and do the very best I can with the patients that God gives me now.
Yeah. Which not only that, you're now making a difference because you're training providers like me who then want to train more providers. And that's how this change is going to happen. Unfortunately, we can't rely on medical school and nurse practitioner school and PAs school to change it right. We have to do it. And not only that, through our patient stories and their testimonials and their before and afters and all those things, that's how the change is going to be made. So to kind of what we were talking about, this WHI study. So the problems with this study is that they studied, so number one, the women the average age of those patients were 63. So that's a little bit old. Like, you miss that window. I always tell patients, menopausal symptoms will start 10 years before menopause, and they can last up to 10 years after menopause. So if you think about that mathematically, that's like 2 decades of feeling like crap, right? And so that's number one. The patients were a little bit older. The other thing is that they studied synthetic hormones. They were not studying the type of hormones that Suzanne and I are talking about. And then the other thing is I always say, like, don't blame estrogen for what progestins did. That was the big thing. But on the plus side of it, what they did show is that estrogen was actually very helpful in reducing things like osteoporosis, dementia, and Alzheimer's disease. And then not only that, the recurrence rate of breast cancer.
Yeah.
And so I always have this conversation with patients too, and I'm sure you do as well. And it's like OBGYNs have no problem putting women on synthetic birth control. Yeah. But you put them on a little bit of an estrogen patch or put a testosterone pellet in their butt cheek and they've lost their damn mind. And it's like, guys, do you understand like the pharmacokinetics of how these things work? They don't. And it's so sad. It's so sad. And then my favorite is when they always fall back, well, you're just seeing a nurse practitioner. And it's like, okay, but I can read and I'm reading the research. If you want a copy, I'll send it to you. But like, it's there. It's not like you got to look hard to find it, which is hard, which is really, really hard. So as far as, the research, unfortunately, they over extrapolated it and all those things. What would you say for you and kind of your clinical experience, the role of testosterone in women? It is astounding to me that there is yet to be an FDA-approved testosterone. The closest we've got is, what is it called? Intrarosa, which is an intravaginal DHEA. They're like, we'll just give them the precursor and hope their body does what it needs to do. Like, well, good luck hoping. But with testosterone in women, what would you say for you, Suzanne? And I know, you and I have both shared, like, we're both on testosterone, but we prescribe it to women all the time. Like, what would you say is the most beneficial or couple beneficial things that you notice with it?
I think it's the general sense of well-being. That's what we get from most women who start on testosterone therapy is they feel this general sense of well-being. There are 2 huge studies demonstrating its safety in breast cancer. Meaning actually diminishing by almost half the risk of developing breast cancer. So that's very exciting using subcutaneous testosterone therapy. Those studies were done particularly with pellets. And so we don't know if we can extrapolate it to subcutaneous injections, but there is some conjecture that might be true. I think that's probably the biggest thing. I think so we know, of course, with the breast cancer then I think also the general sense of well-being. I'll joke with patients that, how your husband can walk past their socks on the floor and he doesn't even see them? You're going to get that way when you take testosterone. And I don't mean that your house is going to be a mess, but I'm going to say none of that matters. The socks on the floor don't matter anymore. And so, yeah, you'll go pick up the socks on the floor because that's just who you are. But it's not going to be like, I hate him, I'm going to kill him, because you're not going to get all that. It's not going to happen because it's not going to bother you. Yeah. You're going to be able to walk past and go, oh, I'll pick up the socks, but not because you're furious. That's probably the other big thing that people report. Yes, osteoporosis, yes, libido, yes, vaginal dryness improves. I have one woman who said she was on the treadmill and she just, all of a sudden she was like, clitoris, 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 because she goes, this must be how men are all the time. Like they think about their partner all the time because all of a sudden I can't stop thinking about my clitoris.
That's amazing. That's amazing. Yeah. So there's a great book that I often recommend to patients. It's called Estrogen Matters. And if you're a patient and you're listening and you're like, the Suzanne and Lexi, they're up to some good stuff and you want to learn more, that is a great book. There's a great podcast that I also listen to. I don't know if you know Dr. Kelly Casperson. She is a urologist, and it's episode 222 because I recommend it that much to patients. And so she's got Dr. Avram Blooming on that podcast. So he was one of the principal investigators of the WHI, and he's an oncologist, and he goes through like almost like an hour narrative. I'll send it to you, Suzanne. It's almost like an hour narrative of kind of like how it was so wrong. And for him, really what it was is his wife got diagnosed with breast cancer, went through chemo, and and he was saying, my wife, she doesn't complain. The one thing she complained about is the cognitive piece of it. Without her estrogen, she's lost her mind. Like she could not remember things. And that it was a turning point for him. And that's when he was like, there's got to be more to this, which then gave him the drive to write. I'm like looking in my office because it was right behind me. I think one of my NPs borrowed it. But Estrogen Matters is such a good book. The physician that Suzanne's referring to is Dr. Rebecca Glazier out of Ohio, and she does a lot of research when it comes to shrinking breast cancer with testosterone with anastrozole. In that, the way I describe it to patients, and I love Suzanne's analogies, the way I describe it to patients is you've got this little estrogen molecule, and then what testosterone does, it's kind of like you're putting the outlet cover. You got the little kid who's trying to stick their finger in the outlet, right? So that's like estrogen and cancer. So testosterone's like the outlet cover, and you're like blocking it so it can't bind to those estrogen receptors. And that's how testosterone. And so there's that research is out there, which I think is so helpful. I think the other thing that, and I know, with patients and they see other providers, is kind of debunking the myths all day, every day about testosterone in women. So I think one of the things that I hear a lot of is it's going to cause cancer. And so, I kind of go back to why I'm not really sure how, but here's what I'll explain to you. And so I do topical testosterone cream, and I do testosterone pellets. And the way that the pharmacokinetics of those two things is they are absorbed and broken down metabolites through the kidneys, not through the liver. And so when we talk about, increasing in fibrin factors and clotting factors and liver metabolites, we don't see that with those. And so that's often one thing, right? Then it's like, well, it's going to cause a blood clot. I'm like, again, when we're talking about how these are broken down, we're just not going through where that clotting cascade is going to be. Another thing that I will often hear them say is, I have to stop my hormones because I'm whatever the bullshit age that their doctor told them they had to stop their hormones. And so they'll say, well, I have to stop it. And I say, why? And then they're like, well, my doctor said. I'm like, but here's the thing. We talk about quality of life for patients, right? So yes, in your mid 40s up to the, like maybe late 50s, you're having hot flashes or whatever. And some women don't. And they'll say, well, why do I have to go on that hormone? I'm not having any hot flashes. And I'm like, I'm going to stop you right there. Think about the things that you don't see and feel: osteoporosis, dementia, Alzheimer's disease, breast cancer. I always say estrogen is a very lubricating hormone. That frozen shoulder, that might actually be improved by giving you some estrogen. And now that testosterone, I got to keep all that beautiful muscle on your body. So as you get older and you fall and break a hip, you've got the muscle on to heal, to recover, to get to that physical therapy, to run around with your grandkids, to go up and down the stairs, to do all those things. And so, I just feel like, as you get patients from other practices, it's like dispelling myths all day long.
Yes. Yeah. Carpal tunnel is another one I thought of as you were going through.
I was like, are we playing racquetball? Yeah. No. I was like, yes. Pickleball, that's a big thing. Yes.
Well, and then prevention of UTIs. So you mentioned before about the urologist, and that reminded me that's another reason why. So how we use topical hormones is we can get a lot of improvement in urinary tract infections, in these chronic recurrent UTIs that our patients experience, as well as hemorrhoids that our patients can experience by using the topical hormones. So tons and tons of reasons. I love the cognitive impairment benefits. We also, didn't even mention before about using patches. So patches are also available. They tend to be itchy. People tend to have an allergic reaction to the adhesive. So I don't use them as often, but it is an option. And those are, if those work for you, those are available through your regular pharmacy, and they are bioidentical.
Mm-hmm. Yeah, absolutely. So let's say you get a patient coming in and we're doing the workup. Are there certain diagnostics that you're like, everyone who's on hormones has to have this done? So like, I'll give you an example. Like for my practice, I'm like, if you're 40, you need to have a mammogram if we're going to be getting on some hormones, kind of thing. Again, and they'll say, well, I thought you said the hormones you're doing doesn't cause cancer. And I say, they don't. I just want to make sure I'm doing right by you. And I've got all the proper screening tools that I've done to make sure that you're in the best state you can be. I get a lot of questions too about thermography. And what I always kind of say is like, I love my job. I love taking care of patients. I don't ever want to have to defend what I'm doing in front of a board. And so unfortunately, mammograms are the gold standard. And so that's what I'm going to recommend. And if you're not willing to do that, then I cannot give you hormones. And I know that there are providers who will take a thermography. I'm just not one of them.
Yes.
And so what about you? Like, I'm just curious to know kind of like, what is your like things that you got to have done?
Yeah. I like a uterine ultrasound.
Oh, okay.
Yep. I agree. I like the mammogram. We do thermography for some patients just because they prefer it. I require them to have had 3 normal mammograms prior to doing a thermography.
Okay.
And then I require them to do another mammogram every 3 to 5 years, just to, we're standard of care. And I will usually give them a referral for mammogram every year. Look, this is the standard of care. You get the referral for mammogram. If you'd like to go for a thermography, here is someone who does it. As long as they're getting one of those 2 and they've had 3 normal mammograms, I'll let that go a little bit. Then we also will look at their liver enzymes. We're going to look at, we're doing a pretty thorough history of their family history of their gut health. Now, a family history of breast or uterine ovarian cancer doesn't preclude me giving them hormones. And one thing I think it's important to say out loud is you might develop breast cancer or uterine cancer or ovarian cancer while you're on hormones. That doesn't mean it was the breast cancer. It was the hormones that caused it. Almost the majority of those cancers that are caused, the majority of the time it's due to genetics or stress or inflammation. Mm-hmm. Or the combination of the 3. The hormones aren't the cause of this. It's genetics, inflammation, and stress. And so if you look in someone's life, almost always, I have a friend right now who has breast cancer, and we look in her life. About a year ago, she went through a divorce. She had a big change in careers. And those 2 things in 1 year made her more susceptible to developing her breast cancer. Now, she has a genetics that made her more susceptible as well. So that was her big hit. And then one of the ways that she used to help her cope with the stress was drinking too much alcohol. So you add drinking too much alcohol, stress, and genetics at the base, and you're asking to develop. Now, the fact that we put her on hormones, was that what caused her breast cancer? No.
I tell patients, you drinking those 2 glasses of wine every single night puts you more at risk than this pellet that I'm about to put in your butt cheek. And you can tell your doctor that. Yeah. So it's absolutely true. So, oh shoot, there was another question. Oh, what have you heard? Because this is new. And so it's on my list of when I go visit you and we have our play dates. It's on my list of like, let's dig into this. Have you heard a personal history of melanoma is a contraindication to estrogen?
So I guess I thought it was progesterone that was it was contraindicated with a history of melanoma. We'll have to be specific and look at that. So
okay.
Question, we'll go look it up.
Yeah, I had a patient ask me that, and I'm like, listen, I've not heard that, but before we proceed with hormones, let me ask somebody far smarter than I. And then today was the day I dig into my research, so I was going to look that one up, but I was curious if you had heard that. Which brings me to my next question. Do you have any like contraindications or certain instances where you're like, you're probably not a candidate for hormones that you can think of?
So certainly I'm not putting anybody who has factor 5 or which is a clotting disorder. I'm going to be cautious about them unless they're on a blood thinner for another reason, being treated for that, then I don't have any problems with them. Even an aspirin. So that would be a consideration. That would be a discussion that we'll have. Active triple hormone receptor positive breast cancer, we're going to pause. I'm going to wait for them to get through their treatment, and then we'll restart their therapy afterward. There's just too much controversy and too much, I don't want to interfere with their treatment. And so in that case, I would say if you are actively being treated for hormone receptor positive breast cancer, I'm not going to treat you actively with hormones.
Okay. Do you kind of with the estrogen? So, we say if you have any personal history of seizures or epilepsy, we're just very, very cautious. Like I would not give them a pellet because once the pellet's in, I can't take it out. I have one patient that I did get a written clearance from a neurologist. She's had a history of epilepsy, well controlled, has had zero any kind of seizures or anything in the last 10 years. And this poor lady, hot flashes every single day, quality of life issues. So she gets a testosterone pellet, but she's on a little Climera patch. And that's actually worked really well for her. So while I always say, like, I've got my set of rules, I mean, there are little tiny baby exceptions to certain rules. But to your point, you talked about factor 5, and I was thinking, like, okay, what do I do with that? If they're on a thinner, I usually will say, I need a written note, like a little permission slip from your hematologist saying that they are okay. And I usually send over, there's a great article, I'm sure you've read it. It's on pellet therapy. It's in the journal of, it looks like Muritas. It's Mauritas. And it's like dispelling, it's like myth, reality. And then it has like the article where that came from. And so like, I usually just like highlight it. I print them a copy and I'm like, have them read this section. It talks about the pharmacokinetics of it. And that's actually worked twice. So I usually will do, like, you need a written note. You need a written permission slip to say we're cool with that. And that's been actually very helpful because, again, it's like quality of life situation here.
And then you're engaging the specialist in the patient's care. That way you're partnering with them rather than going around the back door behind their back.
Right.
And if you go around the back door and they have a problem, then you're asking for getting in trouble. Right.
Absolutely. Yeah.
To engaging them, saying, hey, will you partner with me in this decision? I'm concerned because we're all concerned for the patient's best outcome. That's what we all want, is the patient's best outcome. And so if that means that you go to the neurologist and say, hey, will you collaborate with me in making this decision? That's respectful. It's the right way to go.
Yeah. No, I agree. And then the nice thing is there's some family doctors who will like manage someone's anticoagulants for whatever the reason is. And they say, no, absolutely not. And I'll say, well, did they even read the article? And the patient will be like, no. I'll say, listen, I'm not telling you what to do, but if you would like a second opinion, this is who I would recommend. And then they would go to them, and then the hematologist will either deem them a candidate or not a candidate. So again, it's just, we're all on the same team. We're all trying to make patients better, and we're all trying to help them improve their quality of life and reduce the risk of all these other things. And it's just like, listen, this is not a turf war. I always say I'm a man of the people. I'm just here for the patients, And so, but it's true. It's true. And then trying to build a good network of providers. It's so funny. There's a couple really good family practice docs here in Indy, GYNs. I got a couple oncologists. Like 2. So it's slowly, but you know what I find is the best people that like doctors that I can kind of get on board with the teams. It's because I see a relative of theirs. Like there's a local surgeon where, I kind of took his wife who hated him, and like, basically she's amazing. She's like back to her old self, and he sends me patients. And it was so funny. The other day he sent me an email and he says, I did not realize how few people there were who actually manage hormones. And I was like, yeah, I mean, there's maybe people who dabble in it, but for people like us who really like study it and like look at metabolites and look at all these other things, it's like, there aren't many of us.
Yes.
But we're fortunate in that we get to do what we love to do and, help people. So it's good. Yeah. It's good. I think that was a majority of my questions. I kind of was like, I'm just going to kind of go, expiration date. So is there an age that you're like, I already know the answer, but, is there an age that you stop hormones, Suzanne?
Well, I think of it like insulin, right? If you're giving someone insulin for their diabetes because they're deficient in insulin, you're not going to stop their insulin because they're 80 years old, right? That's not what we're going to do. They're at greater risk for developing osteoporosis, for developing dementia, for developing heart disease. If we know that testosterone and estrogen therapy reverse the risks of those, why would we not go ahead and give them those therapies continuously as they age? Right. The hardest time for us to treat and manage patients, I think, is in that perimenopausal time. And what it really requires on our part is a significant amount of education of the patients, giving them their control. So I will give them a dosing range, like you could do 1 to 5 milligrams or whatever the dose is, and say, I want you to increase or decrease your dose. And here's how you know if you need to increase. And here's how you know if you need to decrease. And then you make the change. Because in perimenopause, your ovaries are every month or a couple months are they're like doing this sort of, let me try one more time really hard and make this work. And so the ovaries are trying to do their job again. And then they kind of give out for a few months. And then they're like, okay, we'll try one more time. So you just have to ride that wave with your body and decrease as your body is producing more, and say, thank you, body, for making more of my own estrogen. I love it. I love it. And then on the months when it's down, you go, I'm going to help you. Here's your crutches to take you through to the next peak again. And then, of course, those peaks become less and less. So the management of hormones becomes less of a struggle as we go on. And then keeping in mind also that things like stress, as it comes in, will affect all the other hormones. As you mentioned early in the talk, this is a symphony. So if your thyroid is off or your cortisol or stress hormones are off, they will affect all the other hormones. So you might have perfectly normal on your labs, estrogen, progesterone, testosterone. But if your cortisol or DHEA are off, they're affecting the way your body can bring those hormones into the cells and use them. So now we need to be aware of that. So maybe you had, between the ages of 40 and 50, where you were just riding this wave and trying to manage and turn up and turn down your doses as the time went. And then, wow, from 50 to 60, you had this nice plateau. And then something really sad or terrible happened that put you in this fight or flight response. There, of course, are lots of things we can do. Lexi is very good at doing some of the neural therapy treatments for that. But so you get to this point where you hit a plateau, or you mess up your plateau because of the stressors that are happening. And you just need to realize that's another time to check back in with your hormone provider to make sure that everything is safe for you to continue, that your doses are proper, and that you're getting what you need. Because I'll see patients whose FSH, which is just a general marker, it's a brain hormone that's produced in response to not enough estrogen. I'll see their FSH go up. They've been fine, like 20, 25 for a couple years. And all of a sudden their FSH goes up to, 80 or 100. And I go, what's happening in your life? They're like, oh, well, my sister just got diagnosed with blah, blah, blah. And we're having to bring her into our house. And my kids have a drug addiction and whatever. And, okay. So we need to adjust your hormones because this is what's happening in your life.
Yeah. Yeah. No, it's so funny. I just had a conversation with a patient, and I say perimenopause is what I call the shit or get off the pot phase. It's like your ovaries can't decide. I'm kind of still working. Oh no, I'm real tired. I'm going to go on vacation this month. And it's like, no. So no, I think you're absolutely right. Absolutely right. So when would you, who or when do you then start looking at hormone? So we do the Dutch test, who do you check that on everybody, or do you have who is that ideal patient, or it's kind of after you've been on hormones for so often, now it's time, when do you do that?
So in a perfect world, I would do it 6 weeks after they start any hormone therapy. That would be the perfect situation. These tests are not inexpensive, so sometimes patients balk at that, and we'll manage if we can. If a patient has a personal or family history of a female cancer, I'm going to really push back on that and say, and I'll have that conversation before we even start and say, look, because of your personal or family history, we need to do a metabolite. In fact, it's often the way that we collaborate in deciding that this is the best course of treatment for the patient. They'll come to me and say, hey, I feel like I really need to be on hormones because I have this and this and this side of the symptoms, but I'm afraid because of my family history and my personal history. And so I will say, great, I totally understand that. You are a unique situation. We're going to test you in 6 weeks after you go. And then I might test you again in 3 months. I have one patient whose sister was recently diagnosed with breast cancer for genetic reasons that she does not have. And so every 3 months, because of her concern, and so I think this is a little bit more than I would normally do on a patient, but because of her concerns, every 3 months I test her Dutch test, looking for dried urine test, looking for her metabolites to make sure that she's not having more problems. She also has quite a bit of stress going on. And so that also helps me to, in a way more detailed way, look at her cortisol and DHEA, her adrenal hormones.
Perfect. We just talked about that in our training academy this morning as like when to look at it. And I pulled out some different cases. And one of the cases was a woman who has been on pellets for at least 2 years. And I'm like, we got to look at your hormone metabolites because I want to make sure that we're doing right by you as far as pathways and are you methylating? Are you under methylating? Are you going down the 4OH? All those things. So, yes, gosh, it's so good. Okay. I think I've got all my questions answered. Where are you lecturing next, Suzanne?
So next, in 2 weeks, I'll be in Dallas at ACAM's 50th anniversary. We're super excited about that and about celebrating. ACAM is the longest community of physicians who's been doing alternative medicine. So it's American
College of Advancement in Medicine.
They were the ones who first taught about chelation, and they just have such a great, such a long history, 50 years. That's as long as I've been alive. They've been teaching about chelation and about alternative medicine. So I appreciate them as the pioneers in this, and I'm honored to be part of that faculty. And then we're doing an online course called through MedMasters on peptides. And then we're doing an online course with, what's the other group? Again, on peptides. Those are both. You're in it too, aren't you?
I'm in the MedMasters ones. I'm doing gut. So I'm doing VIP, which is what we just talked about. That's why I was digging into it. Gut tides. So BPC, KPV, BPC, lorazepatide. I don't know. I'll probably ask you like, hey, I got these 5. Is that good? Yes. I'm talking about gut health, but yes.
Super exciting.
And then are you speaking anywhere like in the fall, winter, A4M? Are you doing any of that?
Yes. So A4M's doing a weight loss mastermind, and they're doing the peptide certification course that they do twice a year. It's in case you're interested in peptides, it is a great course. It's very approachable. The course 1 and course 2, they're 3 days long each. And so you go to wherever they're located, do the course, go home, apply everything that you can. You'll get lots of information to apply. And then the second course also is super helpful, gives you lots of information. And I teach in both of those courses.
Awesome. Well, I'm always a huge student of Suzanne. I love Suzanne. I think she's amazing. If you ever have an opportunity to hear her lecture, speak, I know that there's a lot of practitioners who listen to my podcast. This episode is really geared towards like patients. I'm like, I want you to hear it from someone who's been doing it and who is very well spoken and knows the research. So I will get all of the essentials tagged down at the bottom. I so enjoy you. Thank you so much for always taking the time to help practitioners like myself grow, learn, get better serve patients, and doing all those things.
It's my blessing. Thank you so much, Lexi.